RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa New Zealand and is committed to meeting its obligations as te tiriti or Waitangi partners.
Welcome to Talking O&G, a RANZCOG podcast. This podcast takes a closer look at the latest evidence in obstetrics and gynecology through conversations with leading experts. Most O&G doctors are aware of the current worldwide endometrial cancer epidemic. They may not know that New Zealand is a global outlier on incidence and equity. We have one of the fastest rising rates in the world and the highest Pacific incidence globally. And yet, access to care, including diagnosis, molecular-directed care, and immunotherapy, are less embedded and less funded here than in the countries whose guidelines we follow. The gap between what the guidelines say and what we can deliver is the recurring theme of this episode. Dr Silipa Naiqiso and Dr Sathana Ponnampalam are joining us today to discuss Aotearoa New Zealand response to this situation. We'll be drawing from recent studies published in the New Zealand Medical Journal and RANZCOG and New Zealand Management Guidelines, which you can access via the links in the show notes. I'm your host, Dr Cecile Bergzoll. I'm a gynae-oncologist at Te Toka Auckland. I'm the chair of the New Zealand Gynae Cancer Group and the chair of the Gynae-Onc Committee at the college. Silipa and Sathana, could you please introduce yourselves, your connection with today's topic, and declare your conflicts of interest?
Kia ora, I'm Sathana. I'm a general O&G working at Te Toka Auckland. I have a clinical interest in prevention, early identification and treatment of endometrial cancer, as well as fertility-sparing treatment of endometrial cancer. I've worked regionally in the Northern Region Endometrial Cancer Equity Program, and I have no conflicts of interest to declare.
Kia ora, I'm Silipa, a gynecological oncologist at Te Toka Auckland. I'm on this podcast because we looked at our regional endometrial cancer outcomes data, which was presented at the recent RANZCOG New Zealand ASM. This data is expected to be published in the next few months. Sathana and I have both been members of the Northern Regional Pacific Endometrial Cancer Advisory Groups, and I have no conflicts of interest to declare.
Silipa, could you please tell us a bit more about what makes New Zealand special in the world of endometrial cancer today?
So as we know, endometrial cancer is the most common gynecological malignancy, and New Zealand is no different from the rest of the world where it's rising. New Zealand has one of the fastest rates of endometrial cancer in the world, and the incidence of endometrial cancer has risen about 60% in the last decade. And globally, endometrial cancer is one of the few malignancies for which both incidence and mortality are currently rising. This may be related to the obesity epidemic, since endometrial cancer has the largest correlation with obesity compared with all the other cancers. So unfortunately here in New Zealand, the burden isn't shared evenly. So for Pacific women, the incidence is now described as one of the highest endometrial cancer incidences in the world, with an age standardized incidence of about 45 per 100,000 females. And so for comparison, the highest incidence country is Samoa at 26 per 100,000. And so endometrial cancer is also the fifth most common cancer for women here in New Zealand, behind breast, bowel, melanoma, and lung.
And can you comment on the degree of ethnic disparity?
Here in New Zealand, the endometrial cancer incidence in Pacific people have increased by at least 9% per group in the last decade. And the county's Manukau data, which is out here in South Auckland, shows that the relative risk of developing endometrial cancer is 5 times for Pacific compared to other New Zealand population, and 2.5 times for Māori compared to the other New Zealand population. Māori and Pacific also have poor disease-specific survival, and this disparities in incidence stage, the initial stage, and also in disease outcomes.
And are younger women also getting endometrial cancer now?
Yes, so endometrial cancer used to be the disease mainly for postmenopausal women. However, now that landscape is now including young premenopausal women. Recent evidence has demonstrated that the endometrial cancer incidence in the Pacific people group has increased the fastest for women who are under age 50, with a 12% annual increase. And in 2024, a paper also showed that Pacific and Māori have higher endometrial cancer incidence than European or other women across ages, and that disparity is also uneven. It is widest and worsening fastest in younger premenopausal women while in the older age groups, the ethnic incidence gaps exist, but it's still a bit more stable. Our recent data yesterday presented at the RANZCOG ASM also showed that in women who are under 45, that 14% of all endometrial cancers belong in the under 45 group, and Pacific women made up 55% of that group, Māori 20%, and European 10%. Now, when we stop and compare that to our last census, Pacific people only made up 8% of the New Zealand population, Māori 18%, and European 68%.
And how much does the disparity explain the distribution of modifiable risk factors versus factors we don't understand yet?
So most of endometrial cancer incidence disparities related to a cluster of metabolic risks, although importantly, these don't explain all of it. The dominant driver is excess body weight, with type 2 diabetes and physical inactivity as the two key contributors, and they cluster together. Endometrial cancer has the strongest association with high weight amongst all cancers. So for each 5 kilogram per meter squared increase in points of BMI above 28, this is associated with a more than 50% higher risk of endometrial cancer. There was a recent paper on the projections of gynae cancer in Aotearoa, which estimated that excess weight accounts for 40% of endometrial cancer with Māori and over 50% in Pacific women. And there is a much higher obesity prevalence in these populations. The population attributable risks are even higher when you combine excess weight with inactivity and diabetes. And in the Pacific population, this means that 63% of endometrial cancers can be attributable to these three risk factors. We also know that the diabetes prevalence is also increasing about 7% annually here in New Zealand, and that is 3 times higher in Māori and Pacific people, conferring a 2 to 3 times increased risk of endometrial cancer that's independent of body weight. Type 2 diabetes, excess weight, and inactivity are modifiable risk factors, and that's where we really need to focus most of our efforts on, is really on the reversible part of it. We also know that this is not really an inherited cancer for Pacific women, because Pacific women are overrepresented in terms of the cases, but not among Lynch syndrome diagnosis.
And Sathana, can you tell us about strategies existing in New Zealand to address this crisis and the inequities attached to it?
Sure. So there's currently no population-level strategies for these issues related to endometrial cancer in New Zealand, but there are opportunities to improve outcomes at every level of care. Endometrial cancer was identified as an equity priority back in 2022, and in the northern region there was an endometrial cancer equity program that was established but never progressed because of the massive restructuring in the health system that we've seen. So a bipartisan approach to health policies would ensure that health priorities don't change with government. The recently published guidelines highlight Māori and Pacific populations as priority populations in this area of women's health, and tailored community education programs for these populations, as well as health professional education in cultural safety and competency, will likely improve outcome for Māori and Pacific people.
And you published a New Zealand Medical Journal article which was titled "The Pathway to Action," and it identified systemic changes required to address rising endometrial cancer rates in Aotearoa. Can you talk us through some of the proposed actions in this paper?
Sure. So what we're recommending in the article is a coordinated action across the full spectrum of care continuums, so starting with a community-based awareness program, then preventing endometrial cancer where women are identified as being at risk, and then ensuring that the diagnosis is timely, culturally safe investigations are offered, and improving access to both surgical and non-surgical care for endometrial cancer, as well as endometrial hyperplasia, which is a precancerous state of the disease. We've also highlighted that supportive survivorship care is also essential, and that all these are the things that we've highlighted in the article.
Despite the lack of resources allocated to a concerted national strategy for endometrial cancer, you've led the development of several national guidelines in this sector. Could you please explain how the recently published AUB guideline could help?
Sure. So the guidelines we've published to date include fertility-preserving treatment for both women with endometrial cancer and pre-cancer, as well as management of AUB in premenopausal women. These guidelines can be found on the Health NZ website and will be in the link on the podcast today. And the implementation of this guidelines will ensure that women who, when they present with AUB, they have appropriate and timely assessment, investigations and management of their symptoms. It'll also provide opportunities for women to have a risk assessment, and women who are identified as being at risk of endometrial cancer can have the risks actively managed to reduce their risk of developing cancer. We also hope that the guidelines will improve early detection of endometrial cancer in premenopausal women, and that when referral is indicated to secondary care, that referral is timely and appropriate and escalated to tertiary gynae-oncology services also in a timely way.
Great. Thank you, Sathana. And does this mean that we need faster and more equitable access to diagnosis with ultrasound and PAPEL? And is that what the guideline recommends?
Yes, well, the AUB guidelines encourage investigating women at risk of endometrial cancer when they present, and ideally with initial imaging with ultrasound scan and endometrial sampling, both at primary care level. The most important risk factors for premenopausal women are excess body weight, diabetes, and polyendocrine metabolic ovarian syndrome, previously known as PCOS. We do, however, currently have significant resource constraints despite availability of funding for investigations in primary care. So there are huge delays in our ability to get ultrasound scan in the community and limited availability to access endometrial sampling in the community. So there are plans to improve resource constraint, but training opportunities and resourcing will take time and additional resources.
Mm-hmm.
Did you know that your RANZCOG membership gives you access to a suite of clinician resources? From updated clinical guidelines and statements to RANZCOG and other subscription-based O&G journals to RCOG learning. You have plenty of options to keep up to date on what matters to our profession. Visit the member benefits page on the RANZCOG website to learn more and get the most out of your membership.
So, Silipa and Sathana, you've been both working in the community directly with women to address these risk factors, and Georgie McPherson touched on this during her presentation at the workshop on Sunday. What tips would you give to health practitioners when talking to wahine about the relationship between weight and the cancer risk?
So weight stigma is a widely recognised issue. Women who have reported positive communication about their body weight with health professionals mention features of long-term trusted relationship, respectful two-way communications, and feeling heard by their clinicians in data that's published by Dr. Linda Williams. In my personal practice, I ensure that I choose an appropriate time to have the conversation with the person and ask for their permission. The conversation is often about health habits rather than weight as a measure on its own, and what practicable or realistic goals people can set, and discuss practical ways in which they are able to achieve their goals. So this might be reducing the number of takeaways, for example, or focusing on the number of steps they take rather than their weight as a number on their own. It's important that an individualised approach for patient care is offered when we're discussing weight loss. So for some people, they're able to achieve health habits and a healthier weight by lifestyle measures alone. For others, it's medication or surgery, and for some others, it's a combination of the three. A one-size model doesn't fit all in this situation. Ultimately, what would be ideal is a multidisciplinary service that is easily accessible to women. What we need to improve is availability of weight loss treatment, as often we're able to discuss treatment, but we're not able to offer this to women in the public sector because there's no funding.
Yeah, weight loss medication is not funded in New Zealand. Thank you. So we've talked about incidence, risk factors, prevention and diagnosis. I'd like us to move to treatment. So Sathana, you've led the development of the guideline for fertility preservation management of early endometrial cancer. And Silipa, you've measured the outcomes of this strategy in this population. So Silipa, I would like to start to give us some early results from your study on young women.
So we looked at really the Midland and Northern regional data that we presented yesterday, and there were differences between our outcomes and the international reported ones. So we looked at a regional data from 2009 to 2022, just before the guidelines got released, and our complete response rate was about 59%, with a median time to complete response rate of 9 months. And only about 24% of the patients actually had dual treatment, i.e. Mirena and a progesterone, and a live birth rate of 9%, which is below a recent meta-analysis showing outcomes with a complete response of 74% and a live birth rate of 35%. For young women with pre-cancer or early-stage disease, the uterus is the target of treatment, but really the patient is the target of care, which means that we have a window to address the reversible metabolic risks, which could also improve these response rates. Supporting culturally safe, holistic approach to care in this area, including addressing the modifiable risk factors such as access to weight loss surgery and medicine, is a clinical priority.
We're saying this a lot, aren't we? We'd like to do better, and some of it is around addressing the obesity and the metabolic risk. So for you, Sathana, how can we improve outcomes for these young women?
Well, what would be ideal is to have a prospective data collection of women who have a diagnosis of endometrial cancer and pre-cancer with all relevant outcomes collected, including fertility and pregnancy outcomes. Ideally, we're able to provide accessible multidisciplinary care for women, which would include fertility-sparing treatment with active, individualised, culturally sensitive management of risk factors, which include high body weight and diabetes, as well as access to fertility treatment. And we should continue to collect data to see if a multidisciplinary approach actually affects the outcome, both cancer and fertility-related outcome for these women. Yeah.
So Silipa, endometrial cancer has moved on from type 1 and type 2 that we learned in medical school. We're now using molecular classification with 4 different prognostic groups. How does this affect care in New Zealand?
So since 2020, the TCGA promised molecular classification is now how we organise endometrial cancer or classify endometrial cancer. There are 4 groups, each prognostically quite distinct. You have the one which is polymutated, that makes up 5 to 10% of tumours and have excellent prognosis. We have the mismatch repair deficient tumours, which make about 20% of all endometrial cancers. They have intermediate prognosis and are also immunotherapy responsive. The third one's a P53 abnormal, which makes up about 15% of tumours, and they have the worst prognosis, and they behave like serous, and majority of them benefit from chemotherapy. And the biggest group is really the no-specific molecular profile, which is the largest group, about 40 to 50%, and that's a heterogeneous group, and that's generally intermediate in terms of prognosis. In New Zealand, we currently have universal testing for mismatch repair immunohistochemistry, P53, and hormones, ER and PR. However, POLE testing is not universal. Advocating for universal molecular classification is now really relevant because this helps us stage cancers, but also helps guide therapeutic modalities. We do not have funding for universal POLE testing, which would allow us to implement the FIGO 2023 classification, but also customize adjuvant treatments. The FIGO 2023 staging system keeps the surgical pathological form as its foundation, but it integrates molecular classification, which has better prognostic value. De-escalation trials such as the EN10 or TAPER, measuring the impact of less adjuvant radiation therapy, are currently being considered here, and that requires universal POLE testing.
And that's, you're including patients in the TAPER trial in Auckland?
Yes.
So up to 20% of endometrial cancers are DMMR, you said that, and therefore responsive to immunotherapy. And this is not currently funded in New Zealand. Any progress with this?
So the role for immunotherapy is really in advanced and recurrent endometrial cancer. The lack of access to immunotherapy is another inequity faced by all New Zealand women with endometrial cancer, but specifically for Māori and Pacific because they present at a higher stage. Our national working group, New Zealand Gynae Cancer Group, has been advocating through PharmAC for funded immunotherapy in advanced and recurrent DMMR endometrial cancer, but have had limited success with it.
Work in progress. We're reaching the end of our session. Sathana and Silipa, would you like to provide us with your key takeaway messages for the session?
My key messages are that there's a need for a public awareness campaign, particularly for our Māori and Pacific communities. And there are now clearly defined best practice guidelines for assessment and management of women who present both with abnormal uterine bleeding and postmenopausal bleeding, including a recommendation for risk assessment for endometrial cancer and actively managing modifiable risk factors.
Thank you. And Silipa, your takeaway?
So endometrial cancer is affecting younger women, and the shift is disproportionate to young Pacific and Māori women. The hopeful part really is that a majority of this is preventable by managing metabolic risk factors such as weight. And when it is diagnosed, majority is diagnosed early. So most women can be cured and actually have a good prognosis. Young women with abnormal bleeding need to seek review early.
Thank you so much to both of you for sharing your expertise with us. Listeners, you can find a list of resources discussed in today's episode in the show notes. If you enjoyed this episode, please rate, review, and subscribe and share. And don't forget, RANZCOG members can log CPD hours using the form attached in today's show notes. We'll be back soon with more essential conversations on Talking O&G.